Welcome to the Pulse Report. I'm Dr. Shen, a cardiologist specializing in electrophysiology and the Director of Research and Education in Cardiovascular Medicine. Welcome to today's Your Questions Answered. In this episode, we'll focus on two closely linked questions that often come up together. First, are atrial fibrillation and atrial flutter basically the same thing? And second, do patients experience AFib and atrial flutter the same way? Our goal today is practical clarity, focusing on what truly matters for real-world decisions and outcomes. We'll walk through what distinguishes atrial fibrillation from atrial flutter at the electrical level, and then connect that directly to the symptoms patients experience. This discussion is evidence-based, drawing on research from leading journals such as the Journal of the American College of Cardiology, Circulation, and aligns with current guideline-directed care. So let's begin with the first question. Are AFib and atrial flutter basically the same thing? The short answer is no. They are related, but they are not identical. While both start in the upper chambers, the electrical behavior in each is very different. From a clinical standpoint, both atrial fibrillation and atrial flutter are atrial tachyarrhythmias, meaning the electrical problem begins in the upper chambers of the heart, called the atria. However, the way the electrical activity behaves in each rhythm is very different, and that difference affects how the rhythm feels, how it is diagnosed, and how it is treated. In a healthy heart, each heartbeat begins in the sinoatrial node, or SA node, which acts as the heart's natural pacemaker. The SA node sends out steady electrical signals that spread smoothly across the atria, telling them when to squeeze and move blood into the lower chambers, the ventricles. These signals then reach the atrioventricular node, or AV node, which works like a traffic controller between the upper and lower chambers. The AV node briefly pauses each signal, giving the ventricles time to fill with blood, and then passes the signal along in an organized way. This teamwork produces a regular, efficient heartbeat. In atrial fibrillation, this normal process breaks down at the level of the atria. Instead of one clear signal coming from the SA node, the atria fire many chaotic and disorganized electrical signals coming from many different directions at the same time. I like to say it is like a firework. Rather than squeezing in a coordinated way, the atria quiver. With atrial fibrillation, the AV node is suddenly flooded with these irregular signals. Acting as a gatekeeper, it blocks many of them and allows others through. But because the incoming signals are unpredictable, the timing of the signals that get through is also unpredictable. As a result, the ventricles beat at uneven intervals. This is why AFib is described as an irregular rhythm. There is no consistent pattern to the heartbeat. Now let's contrast that with atrial flutter. Atrial flutter is different. The atria are fast, but they are organized rather than chaotic. In atrial flutter, there is a macro reentrant circuit, which is a dominant electrical loop commonly located in the right atrium. It means that your heart's electrical signal follows a rapid, circular pathway in the atria, producing a very regular and repetitive rhythm. I like to say that it is like a roundabout. With atrial flutter, this loop fires very rapidly, often at a rate of around 300 beats per minute, but it does so in a predictable and repeating pattern. The AV node again acts as a protective filter. Because the atrial rate is extremely fast, the AV node blocks many of the signals and allows only some to pass through to the ventricles. Often, it does this in a predictable pattern, such as allowing every second signal through. This is called 2-to-1 conduction. As a result, atrial flutter often causes a fast but regular heartbeat, commonly around 150 beats per minute. In both AFib and atrial flutter, the ventricles are not generating the problem themselves. Instead, the AV node is reacting to abnormal signals coming from the atria. In atrial fibrillation, the atria are sending out chaotic, disorganized electrical signals. The AV node acts like a filter, blocking many of those signals and letting some through. But because the incoming signals are unpredictable, the ones that reach the ventricles are also unpredictable. That is why the heartbeat becomes irregular. In atrial flutter, the situation is different. The atria are still fast, but they are organized. The electrical signal travels in a rapid repeating loop. The AV node again acts as a filter, but this time the incoming signals are consistent. Because of that, the AV node often allows them through in a predictable pattern, commonly every second signal. This produces a fast but steady heartbeat. On an EKG, AFib shows up in two main ways. First, the normal atrial signal, called the P wave, disappears because the atria are no longer contracting in an organized way. Second, the spacing between heartbeats becomes uneven. The intervals between each ventricular beat vary randomly. Atrial flutter has a very characteristic appearance. Instead of normal P waves, you see a series of regular, sawtooth-shaped waves between each heartbeat. These represent the rapid, repeating atrial activity. The ventricular beats often occur at a regular interval, which is why the pulse usually feels steady, even though it is fast. That electrical distinction is important because it explains both how these rhythms look different on an EKG and how they feel different to patients. So now that we've covered what is happening inside the heart and how it appears on the EKG, let's turn to the second question. Do patients experience AFib and atrial flutter the same way? Although atrial fibrillation and atrial flutter can produce many of the same symptoms, such as palpitations, shortness of breath, fatigue, or lightheadedness, the pattern of those symptoms often differs in meaningful ways. It is not just whether a patient feels their heart racing, but how that racing feels. Does it start and stop abruptly, or does it feel erratic with no clear rhythm? These differences in timing, regularity, and consistency provide important clues about what is happening electrically inside the heart. In atrial fibrillation, the atria send out electrical signals in a disorganized, random way rather than following a single coordinated pattern. Patients often describe it as a skipping, fluttering, or stuttering rhythm, like a drum solo or a fish flopping in the chest. When this happens, the atria stop squeezing effectively. Normally, the atria give the heart a final push of blood just before each beat. This extra push is sometimes called the atrial kick. Without this boost, the heart can lose about 20 to 30% of its normal filling, making it pump less efficiently. That's why patients often notice symptoms that come and go in waves. Many people describe a fluctuating fatigue as if their energy is being drained unpredictably. The heart rate speeds up, slows down, and changes without warning, and the body struggles to keep up. Shortness of breath is also common, especially during activity. Because the heart is not pumping efficiently, pressure can build up in the lungs. Some patients experience anxiety or a vague sense of unease. This is not just emotional. The body senses the irregular signals from the heart, which can trigger a stress response. Others notice lightheadedness or brain fog. When the rhythm is irregular and sometimes rapid, the heart has less time to fill between beats, and less blood may reach the brain. In atrial flutter, the atria fire in a fast but organized loop, almost like a car circling the same roundabout over and over. Because of this, the pulse usually feels fast but steady rather than uneven. Patients often describe it as a constant vibration, a hummingbird-like flutter, or a motor running in the chest. Even though the rhythm is organized, the atria are beating so rapidly that their contraction often becomes ineffective or poorly timed. Instead of a normal coordinated squeeze, the atria may contract too fast to provide a useful filling boost. As a result, the heart may still lose part of that important atrial contribution to filling, though not always as completely as in atrial fibrillation. And the symptoms tend to follow a more steady, predictable pattern. Instead of the ups and downs seen in AFib, the rhythm feels locked in at a fast rate. During activity, this can lead to a persistent sense of shortness of breath because the heart does not have enough time to fill between beats. Many people describe a constant fatigue or heaviness as if they are walking through thick mud or molasses. This happens because the heart rate remains high and sustained, forcing the heart to work harder while pumping less efficiently. Some patients may even notice a strong pounding sensation in the neck. This occurs when the atria squeeze while a valve between the upper and lower chambers is closed. The blood briefly pushes backward toward the neck veins, creating a noticeable pulse. Doctors sometimes call these Canon A waves, but patients usually just experience them as strong neck throbs. Even though atrial fibrillation and atrial flutter can feel somewhat different, they share an important clinical concern: the risk of stroke. In both conditions, the atria may not contract effectively. When the atria fail to move blood forward in a smooth, coordinated way, blood can slow down and pool inside the chambers. When blood stays still, clots can form. If a clot travels to the brain, it can cause a stroke. Modern research, including work our group has reviewed in detail, shows that stroke risk is often related to atrial myopathy. When we say atrial myopathy, we mean that the atrial muscle itself is abnormal or diseased, not just beating in the wrong rhythm, but structurally and functionally altered. The atria are not simply electrical wires. They are living muscle tissue. Like any muscle in the body, they can remodel, weaken, stiffen, or become inflamed over time. Atrial myopathy refers to a spectrum of changes that affect how the atria are built, how they conduct electricity, and how they are regulated. There may be structural changes. The atrial walls may become stretched, thickened, or scarred. Fibrosis, or microscopic scar tissue, can develop between muscle fibers. This makes the atria stiffer and less able to contract effectively. There may also be electrical changes. Scarred or remodeled tissue does not conduct signals smoothly. Electrical impulses may slow down, fragment, or circle abnormally. This instability can trigger or sustain rhythms like atrial fibrillation or atrial flutter. There might be autonomic changes as well. The atria are richly connected to the nervous system. When autonomic balance is disrupted, with too much sympathetic drive or abnormal vagal input, the electrical environment becomes more unstable. This can further promote arrhythmia and alter contraction. So, when we say atrial myopathy, we mean that the atria may be stiff instead of elastic, electrically unstable instead of coordinated, or poorly regulated instead of balanced. These atrial changes usually do not happen overnight. They arise from common medical conditions that place stress on the atrial muscle, such as aging, high blood pressure, diabetes, sleep apnea, heart failure, or valve disease. Over time, these conditions can stretch, scar, and destabilize the atrial muscle, increasing the stroke risks for both patients with atrial fibrillation and those with atrial flutter. Importantly, atrial myopathy can exist before, during, or even after atrial fibrillation or atrial flutter. The rhythm disturbance is often a manifestation of the underlying atrial disease, not the entire problem itself. Because AFib and atrial flutter often come from the same underlying atrial disease, we approach stroke prevention in a very similar way for both. In practice, we don't decide on blood thinners based on whether the rhythm is called fibrillation or flutter. Instead, we look at the whole patient. We use the JACC score to estimate stroke risk, taking into account factors like heart failure, high blood pressure, age, diabetes, a prior stroke, vascular diseases, and gender. Then we follow established guidelines, which recommend that anticoagulation decisions be based on overall stroke risk, not the rhythm label. The reason is simple. Both rhythms often occur in the setting of atrial myopathy. Both can reduce effective atrial contraction, and stroke risk is driven much more by a patient's underlying risk profile than by whether the rhythm is AFib or flutter. So at the end of the day, we treat the risk, not just the name of the arrhythmia. Let's bring this together. Atrial fibrillation and atrial flutter both arise in the atria, but they represent two very different electrical problems. In atrial fibrillation, the firework, the atria, are electrically chaotic, sending disorganized signals toward the ventricles. That chaos is why the heartbeat feels irregular and unpredictable. In atrial flutter, the roundabout, the atria, are fast but organized, driven by a repeating electrical loop. The result is often a rapid but steady heartbeat. Those electrical differences explain why these rhythms feel so different to patients. In atrial fibrillation, The heartbeat tends to feel fast, chaotic, and unpredictable, with symptoms that come and go in waves. In atrial flutter, the heartbeat is usually fast, steady, and locked in, with more constant symptoms. Both conditions reduce the heart's efficiency and can increase stroke risk. This is often because of underlying atrial disease or atrial myopathy, whether it is AFib or atrial flutter. But the pattern of the pulse and symptoms often helps distinguish between the two. The key takeaway from this episode is simple. AFib and atrial flutter are not the same rhythm, and the way they behave electrically explains both how they feel and why doctors approach them differently. Understanding that distinction can help you make sense of what you're feeling and prepare you for the tests, treatments, and care that may come next. In the next episode, we'll build on this foundation by addressing a question that worries many patients even more. Which rhythm is more dangerous, AFib or atrial flutter? If you found this episode helpful, consider sharing it with someone who may be living with atrial fibrillation, atrial flutter, or trying to make sense of a recent heart rhythm diagnosis. You can also find our patient-friendly summary guide linked in the episode notes for easy reference. Thank you for listening to the Pulse Report, and if you've got more questions, drop them in the comments and I'll answer them in future episodes. Make sure to follow the Pulse Report for clear answers to your biggest heart health questions. I'm Dr. Shen, and let's keep your heart and your life going strong and in rhythm.